Dr. Karen Tran Harding. Welcome to Allaei Health and Me, where we introduce you to local inspiring physicians and other healthcare professionals working and living in Southern California. Now remember, if you are seeking your own medical advice, please seek guidance from your own healthcare professionals. Now today we have a very special guest, Dr. Allaei. He is a vascular and interventional radiologist serving many patients with his very successful practice here in Southern California. Dr. Allaei, it's so great to have you here today. Why don't we start off with you speaking a little bit about yourself?
Sure, absolutely. Thank you for having me. I'm happy to be here. So I'm Dr. Allaei. I'm a board-certified vascular and interventional radiologist, like you mentioned. I trained out on the East Coast, but I'm originally from San Diego, so I'm a Southern California native. And I worked for some time in North Carolina before making my way back here. So currently I do practice in Southern California, and I work in a private practice setting, so I see patients both in the office and in the hospital setting. So I do practice both elective medicine as well as inpatient and emergency types of procedures.
Well, it's great to have you back home in Southern California. I know exactly how you feel. I traveled across the country to do some training and kind of returned myself too. So Dr. Allaei,
Yeah,
vascular and interventional radiology is a super, very important field that some people may not know too much about. Could you actually tell us about your practice of vascular and interventional radiology and why you actually ended up choosing that as your specialty?
sure. So vascular and interventional radiology, I think the easiest way to kind of grasp the concept is an image-guided specialty. So everything we do is based on imaging. So modalities such as X-rays, ultrasounds, MRIs, CT scans, etc. We use these modalities to guide our decisions as well as to do the procedure. So we're very heavily reliant on technology, and we use a lot of toys and gadgets to do procedures. Now, this image guidance allows us to do procedures non-invasively. So through tiny pinhole incisions in the skin or none at all, we're able to treat patients' ailments. And some of our procedures are complementary or an alternative to other types of surgeries or procedures offered by other specialties. Now, the confusing thing comes for patients or even family and friends who have no idea who a vascular and interventional radiologist is, comes with the fact that some people say we're a specialist to other specialists. We overlap with so many different fields that it can be a little confusing. I think most patients, when you say interventional radiology, they think of cancer care, which is true, but we also overlap with a lot of different specialties. And that's really the fun of it. And one of the reasons I entered the field is not just about all the toys and technology that we get to play with, but the fact that we get to help out so many different specialties, not only offering these treatments, but sometimes if a physician has a hard time taking care of a patient, or they're kind of out of options, they come to us and see if there's anything that we can offer. So that really makes it very exciting, and to be able to get the patients the care they need.
It is definitely a very exciting field. And like you said, Dr. Allaei, very innovative as well. And you actually touched a little bit upon this about how when you do all these procedures, you actually just use like a small hole to like enter the patient and do the procedure. So obviously there's a lot of benefits to the way that you perform procedures. Other people, like you were describing, you're complementary to other physicians and surgeons. What are the benefits of interventional radiology procedures over more traditional surgery?
Yeah, absolutely. So because we use image guidance, we can do our treatments without making big incisions because, part of interventional radiology is doing your treatments. We look at a 2D image, but we have a 3D object, right, the patient. So there's a lot of creativity and imagination that comes into play in doing our treatments, but the end result is that the patient can get treated without big incisions, right? So that translates into smaller scarring, faster recovery, minimal downtime, and no surgical risk. So since we're not making big incisions, the risk of bleeding is much less, and we don't have surgical risk since we're not doing surgery. So that may be beneficial to someone who's trying to avoid surgery and have something less invasive.
And you also touched upon oncology and how it relates It's to interventional radiology. What are some of the procedures that you actually perform for cancer patients?
Yeah, so there's a lot of involvement of interventional radiology with cancer care, whether it's ancillary procedures, for example, creating an access for a patient to receive chemo or directly treating a patient's cancer. And some of these cancer treatments that we do involve catheter-based treatments or directly treating the cancer with a needle. So catheter-based treatments involve placing a catheter into the blood supply of the tumor and directly feeding that tumor with different agents. So whether it's tiny beads that release chemo over time, or they may release radiation, or they may just plug up the blood supply of the tumor, and this results in the tumor to die and shrink. Another common or popular treatment we do is called ablation. So in certain cancers, we may place a needle directly through the skin without making incisions into that cancer, and these special needles have the ability to either freeze or burn the tumor. Freezing is what's called cryoablation, and burning, depending on the modality, maybe microwave or radio frequency, and these modalities create heat and destroy the tissue, and then that tissue shrinks over time. So the benefits are that, again, because we're not doing major surgery, these procedures have minimal downtime, quick recovery, and have the potential to really prolong patients' life. For example, for kidney cancers, traditionally, if you have a small lesion on your kidney, most doctors will just surveil that with imaging. So they kind of monitor it over time to see how big it gets, and then at some point, you may have removal of the kidney, whether it's partial or full removal to remove the cancer. Now, this is managed very differently. So a patient that has a small lesion will be referred to interventional radiology, and then depending on the doctor's preference or depending on the lesion, we'll do cryoablation or microwave ablation. So we place a needle using image guidance into that lesion, and then we destroy the cancer, and then the patient's cancer-free. And patients go home with a Band-Aid. They don't have any incisions. Most of my patients can't even figure out where I placed the needle, so that's always good. And so patients are very happy after these types of procedures that are offered.
Yeah. Like you said, Dr. Allaei, it's just amazing the things that you guys can do as interventional and vascular radiologists now for cancer treatments. It's not always, about, big surgeries or anything like that. So again, you do such wonderful things for your patients. It's stuff that patients may not even know about. And speaking of other things that patients may not even know about, a pretty common thing in older males can sometimes be, related to their prostate gland, where it might enlarge over time or get something called benign prostatic hyperplasia. You also do, low risk things for those patients as well, too, right? Could you tell us a little bit about that procedure?
Yeah, absolutely. So, as we age, our prostates enlarge, and then it can cause symptoms in some patients. There are a lot of therapies for big prostates. There are a lot of non-surgical treatments that urologists offer, and then you have the gold standard TURP surgery or removal of the prostate gland. So patients who don't want to have surgery, or they may not be a candidate for surgery because they have to be on blood thinners, or there may be some circumstance where the surgeon can't take them to surgery, it's too high risk, or they failed other treatments, would be a good candidate for our procedure, which is the prostate artery embolization. So similar to the catheter-based treatments we do for cancers, very similar concept is we advance a catheter into the blood supply of the prostate, and we inject these tiny beads that block the blood flow to the tissue. And when there's no blood flow, that's when the tissue shrinks, and then the patient's symptoms improve. Again, similar to what we see in cancers, when we block the blood supply or treat it, cancer shrinks. The same thing happens in these prostate glands. Now, the benefit is that it's not surgery, so it's outpatient procedure. It's a tiny nick in the skin through the groin, and there's minimal downtime, just usually that day. And it doesn't have the surgical risks of TURP surgery. The downside is that it does take some time for those symptoms to improve, because we're not going in there cutting and dicing things, so we have to wait for the body to do its thing. And the other downside is that not everyone may be a good candidate. So, for example, someone that has a smoking history, high cholesterol, there may be plaque in these vessels. There's no way for us to get the catheter there. So that's always a possibility. It's important for a patient to have a consultation, talk to an interventional radiologist, really have a good grasp of understanding the limitations and what these procedures can do for them, so that they can make the right decision for them.
Thank you for speaking about those important limitations to your, when you guys do procedures such as vascular calcifications. That's really, really good to know for patients. And, switching to female pelvic organs, something that we hear a lot about are uterine fibroids or muscular tumors of the uterus, right? Hysterectomies are a pretty commonly performed procedure here in the U.S., but you also have a way to do the procedure to reduce or take care of uterine fibroids. Could you tell us about that procedure as well?
Yeah, absolutely. So patients that have fibroids or adenomyosis or combination thereof, typically what they're offered is a myomectomy surgery, hysterectomy surgery, excessive surgery ablation procedures, and they may not know that there is a non-surgical option available for them as well. So similar to the prostate embolization, it's a similar concept. You're going to hear this kind of over and over. But it's a similar concept where you place a tiny catheter into the blood supply of these abnormal tissues, inject tiny beads, and they block the blood flow, and these abnormal areas shrink down and their symptoms improve. So a lot of these patients have pain and bleeding and more symptoms depending on how big their fibroids are or how long their symptoms have progressed. Things do continue to get worse. And so sometimes some of these patients do not want to have surgery, so they just kind of live with these symptoms. Unfortunately, there's some awareness that and education that we need to increase about the procedures available. Embolization for fibroids have been around for over 20 years. It's one of the recommended treatment options for fibroids by the American College of Gynecology. However, I would say 90% of patients I see have come to me just from their own self-research, from going online and reading about it, and that's how they discovered the procedure. When in fact it's a highly successful procedure. It's one of the most successful procedures done by interventional radiology, but it's also the most underutilized. A lot of patients have surgery, did not need surgery. They could have had that embolization. 30%, I'll give you an example. In my practice, 30% of patients I treat have had a previous surgery that didn't work. And when we get an MRI on them that was never done before, what I see is that this patient would have been a better candidate for the embolization. They could have prevented that surgery if they had embolization first approach. Again, this is an outpatient procedure, minimal downtime, there are no surgical risks, and there is a little bit more advantage in some patients to have an embolization because someone who has, let's say, 20 fibroids, it's very difficult for them to get treated by removing each individual fibroid as opposed to having embolization. Because with embolization, we can target all the fibroids at the same time. So that's an advantage that you don't have with surgery unless you're doing a hysterectomy. Hysterectomy is one of the most commonly performed surgeries. And, in some patients, it may be appropriate, but I see a lot of patients who do not want to have a hysterectomy and didn't know about this option. So they've been living with these symptoms for years and years. And after the procedure, they tell me, I changed their life. And this is something, they could have done many years ago if someone had told them about it.
Dr. Allaei, you're so right. I've seen patients post-hysterectomy and also patients that have had, uterine artery embolizations that you guys have performed. And you can see, there's quite a difference in recovery time and kind of pain management afterwards. The people who get the UFEs after, like you said, it's much more minimal recovery time, much, less invasive and things like that. Why do you think, IR procedures like this are kind of underutilized, or why do people not know much about them?
Yeah, so this is the question that I get asked pretty frequently from patients, and it is a difficult question to answer. There's a lot of reasons behind this one. One is this procedure is only performed by interventional radiologists, okay? But patients who have fibroids or adenomyosis, they're not referred to an interventional radiologist, they're referred to a gynecologist. Now, the gynecologist doesn't perform this or may not have experience with referring patients for this, may not be comfortable with referring to someone that they don't know or what the outcome is going to be. Naturally, you want the best for your patients. If there's something you don't know a lot about, may not want to refer a patient to. I don't know all the, it's a multifactorial reason for why patients are not referred for this, but I think, if you're a patient, the best thing you can do is get a consultation with an interventional radiologist. I do see patients who, they tell me, oh, I talked to my doctor and they said I'm not a good candidate for your procedure. When in fact, they're actually an ideal candidate for the procedure. So you really have to hear it from the horse's mouth. It's really hard. I don't tell a patient if they're going to be a good candidate for their brain surgery or their hand surgery, because I don't do those things. So it really has to come from someone who does the procedure, who performs it. And additionally, it's very important for patients to go to a specialist who's going to see them in the office, who's going to have a consultation with them, and is going to follow up with them afterwards. In fact, actually, the consultation and the follow-up care is just as important as the procedure itself. Good patient selection and education and discussion of the limitations of the procedure and what to expect is very, very important for a patient to be happy with this procedure and to have a good outcome. So if it's someone who's just doing the procedure and then sayonara, see you later, you have to question, how happy or what your outcome is going to be.
That's really good information. And you're exactly right. It's really good for the patient to have knowledge of the many different procedures that they can potentially get done as far as medical and surgical management. So like you're saying, you're very complementary to other specialties. So, again, having the public know and patients know that there are really great alternatives is always a really good thing. And also, speaking of gynecology, another of the many wonderful things that you do as a vascular interventional radiologist is to help patients with infertility, right? Could you touch upon those procedures as well?
Yeah, so when you have fertility issues, initially the first person you're going to see is a fertility specialist. And so they're going to work you up and see what's the cause of your infertility. In some cases, they may discover that your fallopian tubes are blocked. So these are tubes that go from the ovary to the uterus. So if both your tubes are blocked, there's no way you can get pregnant because the eggs cannot make it to the uterus. So in those cases, patients are offered IVF or in vitro fertilization. Now, something that a lot of these patients don't know is that there's an alternative treatment for them. And that's what's called fallopian tube recanalization. Okay? So this is a non-surgical outpatient treatment where we place a speculum, much like a pelvic exam or during your pap smear, and we use small wires and catheters to go into the fallopians and flush them open. Now, not everyone is a good candidate, and tubes can get blocked again. However, if I can't open your tubes, now you can try a natural pregnancy, and it's unlimited tries. It's not, every time where you go for an IVF. It's once they're open, and you just keep going until you get pregnant. And in the right candidate, it's a very successful procedure. The other option, which is slightly more controversial, but the data is very good, and that's what's called Lipiodol tubal flushing. So Lipiodol is a sterile poppy seed oil, and in patients who have normal tubes who cannot get pregnant, and there's no reason that they can pinpoint why this patient's not getting pregnant, they can try this procedure called Lipiodol tubal flushing, and it's basically again, like a pelvic exam, similar to an HSG study where we flush the tubes with this sterile form of poppy seed oil. And what they've seen is that it significantly increases patients' chance at pregnancy, especially women that have endometriosis. So these are patients who've never been able to get pregnant before, and then afterwards they get pregnant. However, you do need to have normal patent open tubes for that type of procedure. So both of these procedures are outpatient. There's maybe a one-day downtime. There's no incisions involved, and it's gives these patients a different type of opportunity and chance at getting pregnant.
Yeah. And that's incredible that you do that too, because I know a lot of people don't know that a vascular interventional radiologist can actually help with infertility too. So again, that's incredible work you do, Dr. Allaei. And again, you are a vascular and interventional radiologist, so I definitely want to touch upon the vascular procedures that you perform, especially venous ones, right? Could you talk about those procedures that you perform to help patients out?
Sure. I think the one part a lot of people forget is the vascular part of our specialty. So we're a vascular and interventional radiologists. So we are trained in the arterial side as well as the venous side. Because a lot of procedures I mentioned are, when we're doing catheter-based treatments, they are through the veins or through the arteries. And so this is something we specialize in managing. And there's so many different vascular procedures we do. So it's hard to talk about all of them. I mean, we treat peripheral vascular disease for patients that are facing potential amputation because of poor blood supply, or patients that have varicosities or varicose veins of their legs with swelling or pain. The one thing I do want to talk about that is very underrated and not talked about a lot are treatments for essentially varicose veins of the pelvis and testicles and ovaries. Okay, so patients that have what's called a varicocele, so male patients that have a varicocele, these are essentially varicose veins of the testicles, similar to what patients have in their legs. They have it in their testicles. And then in women, it's called pelvic venous insufficiency. These are big veins around the pelvis and the ovary, and these cause very similar symptoms. They cause pain and infertility as well. So in these situations, well, for males, on the one hand, typically these patients are treated surgically by a urologist. They have different methods, but they do have an alternative approach, which is an embolization. And the way we do our treatment is through a tiny nick in the skin, whether it's in the neck here or in the groin. We advance a catheter down into these abnormal veins, and then we close them down using different types of coils or foam. And it's an outpatient procedure. Everyone goes home with a Band-Aid and maybe a one-day downtime. The same procedure is performed for women, the same process and same catheter-based approach, same recovery. So these are not talked about a lot. Most of the patients that are referred for varicocele embolization, at least for me, they've failed surgery. So they've already had surgery and they're coming to me for embolization. However, it can be done as first line. It's much more simpler to do an embolization on someone who's never had surgery, where their anatomy is preserved. Now, on the other hand, patients with pelvic venous insufficiency, which is also very underdiagnosed. A lot of these patients live with their pain for years and years and don't know that there is a treatment available, or doctors telling them it's just PMS, etc. So these are things that we try to raise awareness, through posting and social media, etc. Trying to talk to clinicians to try to bring attention to these patients.
Again, incredible stuff, Dr. Allaei. And, we were kind of talking about this a little bit earlier about how, the things that you as vascular and interventional radiologists do are so innovative, state of the art. You're using, great gadgets, innovative imaging technology and everything like that. So I know there's a lot of, and you guys do a lot of great research in that space too. So I know there's a lot of great treatments, innovative things on the horizon. And we have about 2 minutes left, but if you could just tell us about maybe the most exciting innovations that are in store for vascular and interventional radiology.
Sure, absolutely. So, part of my specialty that's so exciting is we're constantly reinventing ourselves and coming up with new indications and procedures. So there's a lot to talk about. I think the next wave in my specialty is treating musculoskeletal issues. Currently, we treat knee arthritis. So these are patients that have their joints are healthy, but they may not be candidates for surgery. They're on pain medication. They're getting injections. So similar catheter-based approach. We're going into these abnormal inflamed vessels of the knee joint, and we're treating them. And we're seeing that some of the papers coming out, they're doing this for a lot of other types of joints. So I think that's going to be the next wave. Another thing we're doing here is thyroid goiter embolization. So these are patients with massive thyroid glands who traditionally are treated by surgery with removal of the gland. These can also be treated with embolization or ablation procedures for nodules or the goiter itself. So these are very promising procedures. I think that they're going to grow in popularity tremendously. We see great results with these. And there's many more procedures I can talk to you about as well that
Yeah, and speaking of, musculoskeletal procedures, like you were kind of talking about with, the knee joint and everything, there's also something called frozen shoulder, right? That you guys have innovative treatments for as well that people may not know interventional radiologists perform. We have about a minute left. Could you tell us a little bit about that for frozen shoulders?
Yeah, so frozen shoulders. So these are patients who typically have limited range of motion of their shoulder. They've tried physical therapy, they've had joint injections, and they still have pain, whether it's constant pain or pain with certain movements. So really, the only option for these patients is to have a surgical release, which may not be ideal, for a patient that has a lot of inflammation and scarring in the joint. So another option that the studies have shown very good results, and it's something we do, is embolization of the shoulder joint. So this is again is a catheter-based approach, where we advance tiny catheter into these abnormal vessels, and we can inject something as benign as an antibiotic that closes down these vessels and improves their symptoms. So it's an outpatient procedure. There's no pain. Patients go home with a Band-Aid, and we're seeing good results with that as well.
Amazing. Again, amazing stuff, Dr. Allaei. Again, so thank you again for being here today. The incredible work that you do as a vascular interventional radiologist for your patients, your successful practice here in Southern California is, again, so innovative and just is so wonderful. More patients should know about it. And to our audience today, thank you so much again for joining us on LA Health and Me. Now, remember, if you're seeking your own medical advice, please seek guidance from your own healthcare professionals. Again, I'm Dr. Karen Tran Harding. This is LA Health and Me. Stay safe, stay happy, and stay healthy, LA.
I'm pretty sure you made up Never Too Young.
Toonie, you've got to be kidding me. Never Too Young was the OG, the very first teen soap opera, and that was way back in 1965.
Oh, yeah? Well, what was it about?
Well, Toonie, Tony Dow, that's Wally from Leave It to Beaver, starred in it as a hunky young race car driver named Chet. That was alongside Michael Blodgett, who played Tad, the school's football star.
Wow, all right. Now, Chet and Tad, those are some cool-sounding names.
Oh, and don't forget about Dak Rambo. Dak Rambo played Tim.
Well, Dak Rambo sounds way cooler than Tim.
Chet, Tad, and all their friends all hang out at a hip beach club called the High Dive. That's where rock and roll bands play.
Oh, kind of like the Peach Pit on 90210, or the Ice House on Dawson's Creek, or the Bait Shop on the OC.
Exactly, Toonie. See, I told you, Never Too Young absolutely set the mold.
Oh, well then